Muito boa tarde a todas e a todos, sejam bem-vindos de volta. Esperamos que tenham almoçado bem e que estejam bem dispostos para mais uma rodada de discussões e reflexões. Para darmos início ao nosso quarto e último painel, que trata de sistemas de saúde resilientes, convidamos ao palco a coordenadora da mesa, doutora Cristina Abreu Santos, membro da direção executiva do Instituto Nacional de Saúde de Portugal, doutor Ricardo Jorge. A relatora do nosso painel, que já está posicionada, a doutora Cristiane Vieira Machado, vice-presidente de Educação, Informação e Comunicação em Saúde da Fiocruz. Para compor o painel, convidamos nossos palestrantes a ocuparem seus assentos no palco. Por favor, Dr. Hafton Tam, epidemiologista na unidade de pesquisa do CDC África. Dr. Tomofumi Sone, presidente do Instituto Nacional de Saúde Pública do Japão. Convidamos o Dr. Tonátio Barrientos, diretor do Centro de Pesquisa para a Saúde da População do Instituto Nacional de Saúde do México. Doutora Sara Vibeck, diretora científica da Agência de Saúde Pública do Canadá. Professora doutora Jenny Harris, chefe executiva da Agência Seguradora de Saúde do Reino Unido. Com a palavra, doutora Cristina Abreu Santos. I'm so sorry, Dr. Nathalie Maillet, South Africa CDC.
E agora que estamos todos, agora sim, muito boa tarde a todos. É um gosto estar aqui presente e eu queria aproveitar esta oportunidade para falar também um bocadinho em português. Aproveitar a oportunidade para agradecer à IANPHI este convite tão gentil, mas também à Fiocruz, ao Ministério da Saúde do Brasil, ao professor Paulo Busso, ao mestre Félix também, este reconhecimento por podermos estar aqui todos hoje. Eu penso que posso falar também em nome de outra instituição representante de Portugal que está aqui, que é o Instituto de Higiene e Medicina Tropical, e também apresentar aqui os cumprimentos do professor Tiago Correia, que também está connosco neste evento. Vou passar agora provavelmente para inglês para facilitar o contacto aqui com o grupo dos palestrantes. Just to say that it is wonderful to be here in Rio de Janeiro, and it's a great pleasure to be part of this G20 IANPHI meeting, not only for the excellent scientific program, but also to have this possibility to participate and contribute to this discussion and strengthen the collaboration with the national public health institutes in the world, and in this case that we have here in the room, institutes from the community of Portuguese-speaking countries. I have a partner that is Cristiane, so I'm Cristina, she's Cristiane. Cristiane is the rapporteur, so you are with the two Chris. And we are now starting the last panel. This is a huge responsibility for all of us. We are saying this before coming here to the floor, because the previous panels have been excellent and fantastic discussions. So we will do our best. This topic of resilience health systems has a major importance for national public health institutes, and as you will see, it is related with the previous panels, is very well related to equity, it's related to pandemic preparedness, and all of the things we have been talking about. And as the institutes play a crucial role in protecting and improving public health by conducting disease surveillance, responding to health threats, and addressing all of the subjects that we already talked. I tried to find a definition of resilient health systems, and this could be also a topic for discussion afterwards. But I really would like to present a definition, and one of the possible definitions is that a resilient health system is the one that has the capacity to prepare for, respond to, recover from, and adapt to shocks and stresses such as pandemics, natural disasters, economic crises, or other emergencies, while continuing to provide essential health services to the population. So this is a wide definition, but this definition has different scopes, different perspectives, and I think we could discuss that a little bit more. We know this topic was accelerated after the Ebola crisis in West Africa, and is growing and is more recurrent in the post-COVID recovery. We know also that IANPHI has put in this topic of resilience in previous meetings, and even in Kigali, in the beginning of this year, the agenda meeting has a topic related to resilience. And I was consulting, I was not there in Kigali, but I was consulting the website and the videos from the meeting, and it was shown several presentations and examples that proven the role of national public health institutes in this aspect. And today with this panel, we continue raising awareness, promoting ideas, debating, and sharing experiences in different countries, in different contexts, from different perspectives, focusing on contributions of the institutes for the resilience of health systems. And saying that, I will pass now to the first presenter, that is Mr. Haftom Tame from Africa CDC, that will talk about essential public health functions and how they link with core functions of the national public health institutes and its impact in strengthening health systems.
Okay, so thank you very much. Actually, most of the points that I want to raise are being covered during the morning session, especially when Dr. Shiva was presenting on the essential public health functions, primary health care, and all these things. You will find maybe some repetition of the points, but I want to re-emphasize, the importance, especially the link, interdependency, and complementarity of three principles or three concepts: the essential public health functions, strengthening health system, and the national public health initiative. So my focus will be around this thing. And as you have seen from the presentation done by Dr. Shiva, he tried to give some definitions of these key concepts, and this is already stated in the WHO IANPHI document on application of the essential public health functions. So it starts by defining what a health system is, which is a set of organizations, institutions, actions, efforts, and resources that are aiming at improving, restoring, and maintaining health. Same time, the document also gives a clear definition what a health system strengthening is, And it's an array of initiatives, strategies, activities that improves one or more of the core functions of the health system building blocks. And when you translate that one, what it means practically is a system that has well-trained and motivated health workforce and well-maintained infrastructure, reliable supply of medicines and technologies, which is backed by finance, by funding, strong plan, and evidence-based decisions or policies. And on this part, when the health system, because we are looking about the health system resilience, when the health system is strong, it is resilient under pressure and leads to a greater health security, which means a strong health system can be flexibly, adjust resources and priorities to address emerging public health needs while maintaining essential services. And this is one of the critical gaps or challenges we see in weak health systems, especially from in the continent I came from. When you are dealing with crisis, you completely forget the essential public health services. So we divert our attention, to fighting the fire, and we will be preparing ourselves for the next pandemics or epidemics because we ignore the essential public health service. We ignore the immunization. So tomorrow, we'll be fighting another vaccine preventable disease. And health system strengthening it's about permanently making the health system function better, and it's not about filling short-term gaps. It's about the future and sustainable kind of investment. And a resilient health system leads a greater health security, as mentioned. Then coming to these essential public health functions, I took this figure, especially this figure, and then another next figure from a good publication by WHO colleagues Yu Zhang, Sohel, and the team, because it clearly explains the concept of these essential public health functions, which defines as a fundamental, interdependent, and interconnected activities both within and beyond the health sector that are required to ensure comprehensive delivery of public health decisions and policies. And this unified list of essential public health functions, there are around 4 of them which are service-oriented, 7 of them are system-enabling or system enablers, and the public health intelligence is a cross-cutting because it's both, service and also system enabler in such a way that in the public health intelligence we give alerts and early warning so that this is a service, and we also use this one to track events. And the essential public health functions support a complete health service delivery, starting from the health promotion, protection, disease prevention, treatment, rehabilitation, and palliative services. Again, the essential, when we look, the importance or the impact of the essential public health function to build health system resilience, applying this essential public health function support to achieve health-related goals, including the universal health coverage, health security, and other health-related SDG goals. And we have been discussing in the morning about the importance of strengthening the primary health care, which is, again, following an integrated approach to strengthen the health system. The essential public health functions reinforce the role of the primary health care in the provision of public health services, such as the surveillance, community engagement, and contact tracing functions that help, to build a resilience of frontline health services. And the health system with strong primary health care at the core have lower health costs, better population health, higher patient satisfaction, fewer unnecessary hospital admissions, and greater socioeconomic inequality, because it is very accessible and affordable to the community, which includes in health promotion, disease prevention, education, and rehabilitation services. And how do we how do these essential public health functions help, to build a resilient health system is one, to enhance this public health system with essential public functions is important to ensure and maintain a strong high political commitment. And this can be explained by incorporating the essential public health functions into health laws, health policy strategies and plans, and also having a sustainable long-term funding. Secondly, this application can also be, or this commitment can also be explained by setting up an institution that is responsible to coordinate at least these public health functions. And here we are talking about the establishment of National Public Health Institutes. And this National Public Health Institute is very important, especially in the implementation of these essential public functions at national level. Now, at the essential public health function 3 of this public health, which talks about the public health stewardship, emphasizes having these national structures to coordinate these functions. And in its 3.3 or some function 3.3, it also emphasizes the need to establish these NPHIs with a legal framework so that they can have scientific independence, operational independence, and be able, to carry out, their mandates given given by the legal framework. And so when we see, the essential public health functions are also used as a guide, or they use the guide also to decide the scope and core functions of the national public health functions. And the document that we developed together with US CDC, IANPHI, we consider these essential public health functions to decide or develop the framework for the development of National Public Health Institute. And when you see the functions, essential functions of the National Public Health Institutes are driven from this unified list of public health functions. And the definition that we have for National Public Health is one, they are scientific institutions, government-owned, and they are legally established to coordinate the public health functions at national level. Then the benefits, some of the key benefits of having this National Public Health Institute is increasing efficiency of outbreak detection and response, because it brings together related or similar functions, and this helps us to avoid or reduce redundancy and organizational barriers. And it also increases effectiveness of your interventions by linking key components of the public health functions, and also helps in developing human and physical capacities. In most countries where they don't have the NPHIs, outbreak response or coordination is based on ad hoc basis. So, you establish a team now to respond to Ebola, then when the Ebola is over, these people go back, to their respective institution and respective countries. Similarly, when you face the same outbreak next year or in a few months later, you bring a new people, so it has some impact, on human resource. But if you have this institution which is responsible for that one, it will help, in developing the human and physical capacities in responding to that outbreak. I'm just looking, my time is up, so thank you. So this is like the 3 recommendations I want to recommend for the G20 minister working. One is incorporating the essential public health functions into health laws, health policy strategies, and also for the G20 to help, and advocate for setting up of institutional arrangements, which is basically the NPHI. And most importantly, because they are very economically and politically influential groups, to help in advocating for sustained political commitment, increased funding, improved infrastructure, and resources to support the functions of the NPHIs. Thank you very much.
Mr. Haftam, thank you so much, and you really put 3 strong recommendations. You started with essential public health functions, and then took us to see how to improve core capacities, how to strengthen and to implement public health, national public health institutes, and the importance of this. Also saying the importance of interdepartmental, interconnected beyond whole health sector, beyond health sector. Now I will pass the floor to Dr. Tomofumi Sone. He is the president of the National Institute of Public Health in Japan, and will give some example of Japanese institute activities related to capacity building and the resilience of health systems.
Thank you. It's my great honor to have an opportunity of presentation at this G20 National Public Health Institute conference. Especially, I'd like to express my sincere gratitude to Dr. Duncan Selby and Dr. Sadaf Lines, who enthusiastically invited me to this meeting. I would like to talk roles of National Public Health Institute in resilient health systems, showing some examples of National Institute of Public Health Japan. The mission of National Institute of Public Health Japan is training of personnel of public health, environmental health, and social welfare, and research on these areas. We have 3 WHO collaborating centers shown on the slide. Our origin, former National Institute of Public Health, was established in 1938 with financial support of Rockefeller Foundation at that time. Capacity building of public health personnel of the local governments is one of our major functions. We provide 7 long courses and over 40 short courses domestically with approximately 1,500 trainees annually. Cumulative number of graduates since 2002 is over 56,000. Our courses are free of charge because we think human resource development of local governments should be responsibility of the national government in part. The topic of training courses are HIV/AIDS control, tobacco control, housing, food sanitation, water quality, public health nursing, and so on. A variety of topics we provide. In many courses, ministers' officers are involved in the planning itself. Our training aims not only the improvement of participants' knowledge and skills, but also ripple effect to many other workforces on the front line. For international participants, we co-host international courses with JICA, Japan International Cooperation Agency, on universal health coverage, management, and policy development, and with WHO Western Pacific Regional Office on NCDs and aging. We use online, in-person, or mixed method properly according to the characteristics of the course contents and participants. Before talking about our cost effectiveness evaluation project, I would like to show you a brief summary of universal health insurance system in Japan. It has been implemented since 1961, covering all the people in Japan. The system employs fee-for-service payment method to medical institutions, although a comprehensive payment scheme is partially adapted. The price of each service and medicine is regulated by the Unified Pricing Policy. The National Medical Fee Schedule, that means an official price list, has been revised every 2 years by Ministry of Health, Labor and Welfare. Since 2019, the cost effectiveness evaluation system has been introduced into the price adjustment of medical products with large expected annual sales or prominently high price. NIPH practically plays a leading role in the cost effectiveness analysis and contributes to maintaining a resilient and sustainable universal health insurance system. This slide shows the flow of cost-effective evaluation. As you can see, NIPH demonstrates technical core functions throughout the whole process. As a result, official prices of pharmaceutical products were adjusted in the range of 0 to minus several percent points. In reality, 1% of this figure means huge amount of money. So pharmaceutical companies do not like it. NIPH practically contributed to maintaining resilient and sustainable universal health insurance system. This is another story. The Ministry of Health, Labor and Welfare has made the National Health Promotion Plan called Health Japan 21 since year 2000, currently in the third term with numerical targets on health issues. To implement the Health Japan 21 throughout the country, capacity building and technical assistance such as on-data analysis and visualization for the local governments would be crucial. NIPH plays a leading role in both. This slide shows an example of data analysis and visualization. We make a software open via website to calculate and visualize health statistics or indices of various diseases by a municipality unit. Public health officers in the local government can easily grasp their area's disease distribution, compare with neighboring areas, and show an easy-to-understand chart to the people in the community, including local policymakers. This is a slide of conclusion. We can contribute to the generation of scientific evidence for policy development and implementation at the national level. To implement national policies nationwide, it is essential to increase capacity of public health personnel in the local governments. Capacity building through training is the most important role as a national institution. Technical support for the local governments to implement policies in line with their actual circumstances is also very important, especially in terms of data analysis and visualization of the result. Through training and technical support, national institutes can act as a bridge between national and local governments on policy implementation, which is important for maintaining resilient health systems. Finally, I would show you my opinion on 3 key interventions. Number 1, resource allocation to generate scientific evidence for policy development and implementation. Number 2, capacity building of public health personnel in the local governments to ensure policy implementation on the front line. Number 3, bridging between national and local government policy implementation. I do believe that these interventions are essential for maintaining resilient health systems so that National Public Health Institute should have a leading role to promote them. That's the end of my presentation. Thank you very much for your attention. Obrigado.
Obrigada, Dr. Soné. Thank you so much for presenting your experience of your institute and putting this tonic on the importance of workforce development and capacity building and training of personnel in public health institutes. We now will listen to the experience of the Dr. Tonacio Barrientos, diretor del Centro for Population Health at the Instituto Nacional de Salud Pública in Mexico. And he will present health system reforms in Mexico.
Buenas tardes, voy a hablar en español porque no ha habido suficiente español aquí. Les doy un minutito para que se pongan sus traductores y bueno, lo que creo es que cuando hablamos en español nos tendrían que dar como 2 minutos más porque tenemos un montón de artículos que no existen en inglés. Pero bueno, está bien, haré lo posible. Bueno, quiero hablar con ustedes del proceso de reforma del sistema de salud que hemos experimentado en México en los últimos años y reflexionar un poco sobre qué significa esto para resiliencia. Lo primero que quisiera decir es que México, como muchos otros países de América Latina, tiene un sistema de salud altamente fragmentado. Creo que tenemos más o menos 8 instituciones de provisión de servicios médicos públicos, más desde luego privados. El más grande de ellos es el IMSS, que es el Instituto Mexicano del Seguro Social, que es el sistema para trabajadores formales. Tenemos el ISSSTE, que es para trabajadores del Estado. Y tenemos después otros, por ejemplo, el del Ejército, la Marina, la Compañía de Petróleos. Y luego finalmente tenemos un sistema público que es para las personas que no tienen seguridad social y que por muchos años fue financiado por el Seguro Popular, que era, digamos, una forma de obtener recursos de las personas que no tenían seguridad social y que también, digamos, había un match de financiamiento por parte del Estado para poder cubrir un número específico de intervenciones curativas cuya finalidad principal era reducir los gastos catastróficos en salud. Solo para darles una idea, antes de la reforma, en 2018, México estaba gastando más o menos 4.8% de su Producto Interno Bruto en salud, lo cual es bastante bajo, y llevaba a que más o menos la mitad del gasto en salud se hiciera gasto de bolsillo, ¿no? Out of pocket. Desde luego, el porcentaje de ese Producto Interno Bruto que se iba a funciones esenciales de la salud pública distintos de atención a la salud era extremadamente bajo. Bien, tuvimos 2 reformas en los últimos 6 años. La primera fue el INSABI y básicamente el INSABI fue la manera en la cual se había pensado la transición del seguro popular hacia otro sistema, hacia un sistema más universal y gratuito. Desafortunadamente no fue, digamos, un sistema que haya tenido la capacidad de evolucionar hacia este sistema y bueno, desde luego COVID tuvo mucho que ver, pero también, digamos, hubo otra serie de razones por las cuales este sistema no funcionó y en 2023 fue cancelado. Y entramos a un nuevo momento, digamos, dentro de la reforma que se llama ahora IMSS Bienestar y que tiene este sistema que se llama Más Bienestar, que está basado justamente en estas características de gratuidad, accesibilidad, oportunidad, cobertura universal, continuidad y calidad y que busca proporcionar servicios, por un lado individuales y por otro lado de salud colectiva para la población mexicana, a partir, digamos, de todos estos principios y reconociendo además que la provisión de servicios de salud tiene una estructura multinivel, donde por un lado tenemos que estar involucrados en políticas de salud, pero después tenemos que estar trabajando a un nivel territorial muy bajo. Quisiera darles una idea rápida de lo que esta reforma ha significado. Esto que están viendo aquí son los últimos datos que tenemos, son datos de 2023 respecto de la demanda de atención y de la manera en la cual estamos cubriendo la demanda de atención, ojo, cuando hay una necesidad de atención en salud, es decir, cuando alguien está enfermo. Y lo que van a ver en general es que a lo largo del tiempo, solamente hemos visto un momento de incremento muy alto en el número de personas que buscan atención. Si se fijan, por ejemplo, de 2006 y 2012 teníamos muy baja búsqueda de atención y luego la búsqueda de atención creció mucho entre 2012 y 2018 y me encantaría decir que eso es porque nuestro sistema de salud creció y pudimos dar más atención gratuita, pero la realidad es que lo que sucedió es que México introdujo un sistema de solicitud de antibióticos que requería de una receta médica. Y entonces, en respuesta a este requerimiento, las farmacias privadas establecieron consultorios adyacentes muy baratos, muy eficientes, muy rápidos, que empezaron a proporcionar los servicios de atención primaria a la salud que nuestro sistema no podía cubrir. Y luego, más adelante, a partir de 2020, tuvimos desde luego ahí una caída bastante grande por COVID y hemos empezado a ver una recuperación, sobre todo del porcentaje de personas que están recibiendo atención en servicios públicos hacia los últimos años. Entonces, bueno, el sistema va trabajando, va muy lentamente, pero vemos ahí señales alentadoras en términos de acceso, por lo menos, a la atención. Ahora, lo que sigue siendo un reto, y me parece que va a seguir siendo un reto por un buen rato, es la calidad de la atención. Esto que están viendo aquí es la trayectoria que siguen las personas que ya tienen diabetes diagnosticada en mi país, en México. Y lo que van a ver, por ejemplo, en la parte de arriba, aquí arriba, justamente en esta línea, es la trayectoria que sigue más o menos el 60% de la población que tiene diabetes, quienes están yendo por lo menos una vez en el último año al médico, que tienen tratamiento farmacológico indicado y que además lo toman regularmente. Eso, por ejemplo, comparado con 12% de la población que tiene diabetes, que está yendo a la consulta por lo menos una vez en el último año, que tiene tratamiento indicado, pero que no lo toma regularmente, y así en adelante. Ahora, ¿qué es lo que es verdaderamente preocupante de esto? Que incluso en el mejor caso, cuando cumples con las 3 condiciones, el porcentaje de control de diabetes es solo del 34%, y ese es el mejor nivel de control que estamos logrando. Entonces, ¿por qué si una persona accede a los servicios de salud, si tiene tratamiento indicado y lo está tomando, tiene un porcentaje de control tan bajo? Y desde luego, no es un problema ya de accesibilidad, es un problema de calidad, es un problema de prescripción y desde luego es una falta de entendimiento de qué está sucediendo específicamente con el uso de estos medicamentos por parte de las personas que los reciben. Bien, una cosa que vemos con mucho entusiasmo es la creación dentro del Más Bienestar de esta capacidad de ofrecer servicios de salud colectiva, que era algo que no existía previamente. Bueno, había algunas capacidades, pero no habían sido puestas ahí, no habían sido visibilizadas con tanta potencia, y particularmente la creación del Servicio Nacional de Salud Pública, que es un cuerpo de personas parecido, digamos, al core de salud pública que tienen los Estados Unidos, cuya función es servir de articulador entre el sistema nacional federal y los sistemas locales, con una localización territorial que facilite la integración de los mandatos federales hacia las áreas locales. Pensamos que esto puede tener un impacto enorme en la resiliencia de nuestro sistema de salud, no solamente porque creemos que van a poder hacer muchas cosas que no habíamos podido hacer, sino porque además este cuerpo puede transformarse, digamos, en un pequeño ejército de personas que organizan la respuesta en el caso de que ocurra un desastre o una emergencia sanitaria. Me queda un minuto y lo voy a aprovechar para mis 3 recomendaciones. Hablando específicamente de sistemas resilientes, me parece que una de las principales cosas es no olvidar que para que los sistemas sean resilientes, las poblaciones tienen que ser resilientes. Una de las cosas que observamos en México, que quizás ustedes lo sepan, pero México fue uno de los países que tuvo mayor mortalidad por COVID a nivel mundial, y una de las razones importantes para eso fue la altísima prevalencia de enfermedades crónicas. México tiene casi el 70-75% de la población con sobrepeso o obesidad, 20% con diabetes, 40% con hipertensión. Con esos niveles es muy difícil que un sistema de salud pueda salir adelante cuando tienes una emergencia de este estilo. Entonces, no es únicamente trabajar en el sistema, digamos, en el sistema de salud. Podrías trasplantar el mejor sistema de salud a México y de todas maneras seguiríamos teniendo enormes problemas en los siguientes años, simple y sencillamente porque hemos dejado que nuestra población en términos biológicos y sociales tenga enormes retos generales. Esa es la primera. La segunda es que no todas las funciones esenciales de la salud pública son igualmente elocuentes. No hay movilizaciones sociales para pedir que haya mejor monitoreo de las enfermedades o para pedir que haya más financiamiento para hacer investigación en salud pública. Necesitamos poder comunicar hacia los tomadores de decisión, hacia el G20, la absoluta necesidad de que se financien todas las funciones esenciales de la salud pública de forma completa y no de manera parcial. Y finalmente, la enorme dificultad que vamos a tener muchos de los países, algunos más que otros, para poder construir sistemas de salud que sean verdaderamente resilientes de manera aislada. Los planes de resiliencia no pueden ser planes únicamente a nivel nacional. Necesitamos que haya una visión internacional muy clara, tiene que haber equidad. Vemos con buenos ojos el acuerdo pandémico, pero también nos preocupa la equidad dentro del acuerdo pandémico que asegure que nuestros países puedan tener un desarrollo que les permita sobrellevar mejor la siguiente pandemia o el siguiente desastre. Muchas gracias.
Thank you very much, Dr. Barrientos, for presenting this Mexican system reform, health reform, for a better access, but also guaranteeing quality of care, and also the topics you mentioned, the need of investment in public health functions and the other subjects. Thank you so much. And that could be, I think the audience will have many questions regarding these interesting presentations. I will now pass to Dr. Sarah Vivek from Public Health Agency of Canada. She's Chief Science Officer and Vice President for Data Surveillance and Foresight for the Public Health Agency of Canada, and we'll talk about national to subnational approaches to health systems resilience.
Thank you, dear colleagues and the other panelists, and I will spare you too much Portuguese, but I will say to our organizers, obrigada e parabéns à equipe da Fiocruz pelo maravilhoso encontro. I'm very grateful to you for your kind and warm hosting and for the invitation to be here. And félicitations à nos collègues de Santé publique France pour IANPHI as well. So I will speak with you today around several key messages related to health system resilience. The first is that from intense disruptions, as we have just lived through, innovations can emerge. The second is that a health system of systems like the one that we have in Canada can benefit from defining system elements, including essential functions, and we've heard about that already from colleagues this afternoon on the panel, and also from a shared understanding of what makes a system high-performing. And lastly, that resilience can be demonstrated and reinforced across national and subnational levels through joined-up intentions, actions, practices, technical collaboration, and capabilities. I could spend a very long time on this, and I won't. I'll simply say that there is a long relationship between the federal and provincial and territorial governments that defines our health system, which includes a federal role for playing leadership through funding, convening, regulation, legislation, targeted programming, and collaboration, and the delivery responsibility and how those resources are allocated rests with provinces and territories. And we sit around many shared tables through governance mechanisms to identify and move forward where appropriate and deemed deemed actionable by provinces and territories, areas of shared interest. We have a public health expenditure that accounts for approximately 5% of our total health expenditure budget. And these are estimated figures because the ways in which public health is organized across jurisdictions varies considerably, which makes it quite difficult to compare and collate numbers across provinces and territories. Our own agency, the Public Health Canada, turns 20 indeed this month. We're an agency that emerged from disruption, and particularly around the first SARS crisis. And I'm humbled to be in the room with one of the founding fathers of the agency, my colleague from the provincial level in Quebec. We have, from the outset, had a strong ethos and integration in our enabling legislation of the joining up of evidence and action, with our Chief Public Health Officer being charged with the legislated responsibility to provide both our minister and also the president of the agency with public health advice formed on a scientific basis. We are not alone in being a public health agency in Canada, as I alluded to. We have 3 provincial public health agencies in Quebec, in British Columbia, and in Ontario, and we work collaboratively with them as well as with public health institutes that are based within ministries of health at the provincial and territorial level. If we take the COVID-19 pandemic as another very extreme case of disruption, far more extreme, of course, than the disruption that led to our creation, we can see that not only that pandemic, but also the increasing, as we've heard from several speakers at the meeting so far, the increase in the complexity and frequency of public health emergencies or emergencies which necessitate a public health response. We really are pressed to continue to need to understand how to operate and behave as a system of systems, respecting our respective roles and jurisdictions and accountabilities. I would offer that there are a number of system elements and properties that may emerge in that kind of context around innovation, as I've said already, around interconnectivity and the need to work across boundaries, and we've heard quite a bit about intersectoral work already at the meeting, around adaptability and adjusting approaches on the basis of feedback loops, on how we organize ourselves and how we do so in a nimble and adaptive way. As part of that, we have an opportunity through a big feedback loop, which is the lessons learned from the pandemic, to consider what we could be doing better as a system of systems. And we've looked across a number of reviews across jurisdictions in Canada, audits, evaluations, and also experiences of practitioners to generate a number of lessons learned about our responses, including how we are governed and collaborate together, and our own roles and responsibilities as part of the system, given our federal jurisdiction, how we address and apply health equity in policies, programs, and our work, how we generate surge capacity for the public health workforce, how we ensure access and to both quality and timely data for decision making, how we communicate, and also how we integrate science and technology. We have many challenges to resilience, however, and I think many of the speakers have touched on these so far. And so I'll offer several examples of how we've tried to address resilience in a post-pandemic context. The first is around defining a public health system and measuring its performance. And during the pandemic, our Chief Public Health Officer released her annual report, which reflected on the foundation, tools, and principles of a world-class public health system from her perspective. I think that these have been reflected on in different ways by other speakers. We have tried to seek to understand, though, to take those elements of a world-class public health system and understand how it's measured. And of course, none of you will be able to read what's on the screen, nor do you need to. The message is that we've looked internationally at counterpart national public health institutions to understand how those essential public health functions translate into the measurement of public health system performance. And we observe, and this is work by Dr. Sarah Allen in Canada at University of Toronto, that there's tremendous variability in how we capture a shared understanding of the effectiveness and efficiency of our structures, processes, and outcomes. That's not only true for international comparators, but it's also true when we look at provinces and territories, and the variability in how things are measured and to what end. So we're working with our Canadian Institute of Health Information as part of operationalizing a shared action plan related to public health data to work with them to actually generate a shared set of public health system indicators with provincial and territorial governments in order to look across system levels to understand what makes effective structures, processes, and outcomes. This will provide us then a base for understanding our respective and collective impacts in public health. I'll offer now several other examples of where we have tried to generate the elements to support resilience, including through shared strategies and commitments. And Canada went into the pandemic with the absence of a shared biomanufacturing and life sciences strategy. This strategy, which was developed in 2021, lays out a plan for the country's not only biomanufacturing capacity, but also the necessary laboratory and research infrastructure and clinical trials capacity, collaboration across sectors, including the role of government, the role of industry, and the role of academia. Another example of shared strategy and commitments has come through the adoption and generation and adoption of a Pan-Canadian Health Data Charter. And as I alluded to, shared measurement capacity, but also data sharing across jurisdictions has been one of our chief challenges. And so this Pan-Canadian Health Data Charter, which reflects a concrete outcome from shared commitments to health data sharing, reflects a core set of principles, really, that will exist across jurisdictions where this is adopted in order to better generate the evidence to underpin public health decision-making. We're continuing to integrate this data charter, which really is reflective of a shared commitment and intention, into action. And through federal, provincial, and territorial collaboration, we've generated an action plan around improving our health data mechanisms to ensure that we collect and share high quality and comparable health information, that we adopt interoperability standards, that we implement policies and legislative frameworks to support health data sharing for the public good, and advance principles as outlined in the charter that I referenced a moment ago. We're working together around joined-up approaches, and this is an example around technical collaboration for One Health risk assessment, an area that we recognize is not only in the domain of human health, but in the domain of environmental and animal health. And so providing a frame for technical collaboration for shared commitments to risk assessment across jurisdictions. And lastly, I'll offer the example around workforce capabilities and ensuring that we have surge capacity in place where needed to support jurisdictions in addressing both outbreak response, but also technology transfer for laboratory services across jurisdictions. I'll close by noting that there are a number of examples where resilience cannot be achieved alone. Indeed, for system resilience, we need to work together. And so I'll conclude by offering several considerations for this meeting, including the importance of continued participation and support for multilateral and international organizations, the importance for sustained investment, and lastly, the importance of sharing information, lessons, research expertise, and technical collaboration across jurisdictions as core elements to resilience. Thank you.
Thank you, Dr. Sarah. This is a really good sentence. Resilience cannot be achieved alone. And you give some examples of strategies, share strategies and commitments with concrete action plans, joint approaches, and shared capacities. Thank you so much. Now I will pass the floor to Dr. Nathalie Maillet, the Deputy Director of the National Institute for Communicable Diseases in South Africa, and we'll talk about the importance of multi-sectoral surveillance for prevention.
Good afternoon, colleagues. It's indeed a privilege and a deep honor for me to be invited to share the panel with its esteemed members and colleagues. And thank you to Fiocruz for your gracious hosting, your generous hospitality, and to all those who made this possible for this event to take place. Really appreciate it. I'm talking on really a topic that has got three huge principles. Multi-sectorial is a topic, an event in itself. Surveillance is an event in itself, and prevention is an event in itself. So in terms of trying to collate and share some experience in defining what is multi-sectorial surveillance for prevention. And certainly it's coherent. I think that's the first thing. It's well integrated. It's grounded in integrated disease surveillance systems, as was mentioned previously. And it's an all-of-government approach characterized by broad commitment with, from, and involves the entire population. And I think it involves across the political system, and that for me embodies the multi-sectorial surveillance system. But within that collaborations, there are many, many stakeholder groups that are involved. It includes government, the state sectors, from tourism through transport, through environment, and the financing, health economy. We've mentioned many times civil society, but we often forget the private sector as a key stakeholder and a key role player. And certainly this multi-sectorial surveillance crisscrosses disciplines, it crisscrosses fields of expertise, but it also crosses vertical programs that we often, sometimes I think we are our own worst enemy by creating them in the health system. So IANPHI did a lot of work funded by Gates, done in collaboration with many of the expertise around this, in this group, and to determine the understanding of what is integrated disease surveillance. And certainly there is no uniform understanding and collective understanding. It was presented to WHO, and the debates continue to rage about what is integrated disease surveillance and what is its strategy. But it's really an ecosystem. And an ecosystem has got multiple parts, multiple stakeholders, and it involves everything from policy through to culture, which we often forget, systems, the infrastructure, the processes, and of course our social determinants. So it's cross-cutting, but it requires adaptive programming, and it brings efficacy to achieve collective policy outcomes. And I think when we make recommendations to G20, it must be recognized and acknowledged that there are multiple supporting documents that have been developed with the expertise of public health experts, multidisciplinary expertise, that are good sounding boards for informing the framework of where we need to move to. And I just want to flash some of these documents. I know they've gone into some of the details, but are we really marketing the content of these documents appropriately to our non-technical colleagues, to our political colleagues, to the policymakers? And I think this is a key question that we need to ask. So if you look at the WHO collaborative surveillance document, clearly it articulates that this is beyond the health sector. And I would really like to ask how many people in the healthcare sector at grassroots level know about this document. So are we doing ourselves justice by communicating these high-level policy documents down to facility level? where multi-sectoral surveillance is so critical. Are we really bringing the public health intelligence intentionally into our healthcare system, into our communities, by us sharing with what it means? What is public health care? What is public health intelligence for the household living in an informal settlement on the corner? What does that mean for them? And how does it enable decision-making of that politician who is serving that group of people living in those conditions? So I think we've largely separated our surveillance activities into silos. And so it goes to the funding that gets separated into silos. And 60% of current funding for surveillance is around disease-specific programs. And I think, is this an opportunity for us to start changing that paradigm in terms of how we fund surveillance rather than it being vertical programs? There's a linkages document that was developed by US CDC. And again, an excellent piece of work that's tactical. And I quote some of these terms from the document. It's functional, it's multifunctional, multi-sectorial, multi-level stakeholder mapping of the functions of NPHIs. An excellent piece of work as it filtered down, right down to our granular level at our healthcare service of what linkages means. Because really, when we talk about linkages, we have to ask ourselves the questions: who are we serving? Are we serving our patients? Are we serving our taxpayers? Are we serving us as citizens? Are we serving our customers, and are we meeting their expectations? As consumers, are our needs being met? And as care providers, which we often forget, those care providers, are we serving their needs when we talk about multi-sectorial surveillance and linking? And I think we start, as public health institutions, maybe we need to pivot into starting to analyze the contributions made in terms of multi-sectorial surveillance of all of these key stakeholders and role players. This is a very complex matrix and a cube of all the moving parts in multi-sectorial surveillance. We presented this in a book on science and political interface of post-pandemic, and I really just changed the title of this, and it's so apt. You can really apply this model because one moving part affects all the other moving parts. And this matrix and this cube involves another D of the 3 Ds that we so often forget, the decision making. And we found that that is a huge constraint and an inhibitor to moving decision making forward, is that people just don't make decisions in the public health, or it takes long to make decisions. But those decisions need to be grounded in trust, and certainly we need to factor in the impact of this. This is an example of only the National Health Normative Standards Framework of Interoperability in South Africa. It's a 381-page document. But this is the extent of the one IT system for interoperability in one country, 381 pages. And look at the complexity. So the question again, a rhetorical question that I ask, are we being pragmatic and practical about our ask? What do we want to achieve? So there are proposed solutions to this polycrisis. We need to be intentional and purposeful about multi-sectorial surveillance. Is health resilience the right term, or is social resilience the term we should apply? Should we move away from disease surveillance to health surveillance? How do we incorporate these multiple social parameters? And many of the colleagues shared some of those. NPHIs can be the conduit, but they have to be well-resourced and they have to be recognized as that conduit. So as we define the norms for multi-sectorial surveillance at all levels, some of the things we could do is starting to link malnutrition with price indices. What are our household food security indicators? What do we measure when we talk about the mental health of our healthcare professionals and our caregivers? Can we link facility level data, output data, with that of quality of care and satisfaction indices for patients? Can we link health to peace initiatives? There's a colleague in South Africa who's linked burns with energy poverty, because in households they're using these primer stoves to generate heat. Children are getting burnt. These things are and paraffin heaters are exploding. And so, in conclusion, there are a few things that we need to consider, and these are principles. The first principle of integrated multi-sectorial surveillance is legality. Is there a legal framework for this? Are the legitimate functions corresponding to the organizational structure of the institution responsible to do this? And it doesn't have to be one institution, it can be multiple. What's the necessity and the need of the communities that we're serving, and are we serving that need? Again, the proportionality and representation, and what safeguards do we put in place to ensure it's ethical, information is dealt confidentially, and there's transparency. What about non-discrimination and the platforms for engagement in terms of trust? There's a World Bank report called the Green Swan Report. It speaks to climate change, and we can really cut and paste surveillance or health into that where climate climate is used. We can swap it. But what this Green Swan report calls for is an epistemological break of our current thinking to where we want to be. And it talks to resilience of complex adaptive systems, which we've discussed. So the recommendations that I'd like to propose is to advance the legal framework of NPHIs into the office of the President. Now, this is an interesting phenomenon, and where NPHIs don't report into the Ministry of Health, but they report directly into the President's office. Is that not the place where we should be to influence health and social determinants? We need a unique patient identifier for all surveillance systems. We all have a passport, or we all have an identification number. Let us move and make a recommendation that that should be the core tools for across laboratory information systems and all health information and social information systems. We need to rapidly accelerate resourcing to build human resource capacity in terms of data to policy initiatives, so that every NPHI as its output as a data to policy brief that can be tracked, measured for implementation at policy level. And I've mentioned earlier in my discussion, the previous session, about social anthropologists and diplomacy training. I thank the panel, and I thank you for your attention.
Thank you, Dr. Natalie, that introduced us and gave us this importance of the multi-sectoral surveillance, reinforcing the need of an all-government approach with civil society, private sectors. But you presented it as a complex matrix, but giving us also some principles that we need to look upon to progress on this important topic of multisectoral surveillance. And our last panelist is Professor Jenny Harris. She is the Chief Executive of UK Health Security Agency, and she's going to speak about One Health's approach to build resilient health systems.
Bon dia. Can I just extend a really big thank you to Fiocruz particularly, but I think all of the National Public Health Institutes here today, and to IANPHI for their organisation. It does feel to me that if we're all back in Brazil, where IANPHI was first envisioned at a meeting aligned to the G20 timetable, it feels quite historic. It feels as though we are moving up to an opportunity of more potential influence and, importantly, more impact. And I hope that an example I will share today will signal that the UKHSA, in its own small way, has found more opportunities to move in different circles and potential influence in the UK since the pandemic. But this is looking at the other end of the lens at a strategic level. And it's both how we see the One Health agenda and how we are working in different resilience and security spaces across government departments. And as I start, I should say at this point that we find it just as difficult as everyone else. So from what I've heard today, I think we're all agreed that building and sustainably maintaining resilient health systems requires a really multifaceted approach that needs to include enduring political will and governance, a well-trained, sufficient workforce, robust and integrated information systems, as we've just heard, sustainable financing, strong practices of community engagement, and a commitment to continuous learning and adaptation, and a whole lot more. And we can see those numerous building blocks on this slide. And these components need to work together to ensure that health systems can withstand, respond to, and recover from crises while maintaining essential services and promoting those long-term health outcomes. But we can't view, address, or enhance human health in isolation. We have a modern world with increasingly complex health crises, and the forces behind those risks coalesce and summate, including the wide-scale triple impacts of climate change, of pollution, of biodiversity loss. And we all saw that very visibly in Dr. Eduardo's powerful graphic yesterday. We are increasingly a planet in intensive care. So it's essential in our efforts to develop resilient health systems that we always consider, collaborate, coordinate, and communicate with workforces across the One Health sectors of human health, animal health, plant health, and environmental health. Now, although the concept of One Health can actually be dated right back to ancient Greek thinking by Hippocrates, and although in the UK, our public health agencies formally adopted the One Health approach to health challenges in the early 2000s, in the UK, we still haven't cracked it. But our One Health concept is now evolving significantly, and what I wanted to do was share a few of our past programmes and some future developments that we're working on now. Over the last 20 years in the UK, we've worked across sectors on shared priorities, predominantly in the intersection of, in the areas of intersection between the One Health disciplines. And that's been quite a good starting place. So we all end up piling in our resource into that spot in the middle. But as many of you will recognise, operationalising interdisciplinary working in those siloed government structures, which have distinct funding mechanisms and responsibilities, has not been without complications. So with some perseverance of our workforces across those different sectors, we've now made some quite significant strides on how we've robustly and in some cases sustainably embedded the One Health approach into our mechanisms for detection and response, because the UKHSA is primarily a health protection and science NPHI. So, for example, for AMR surveillance, since 2007, we've worked across government departments to collate and publish data on antibiotic consumption and resistance from human and animal and food sectors. And that One Health insight has been integral to informing a fully integrated and aligned UK One Health 20-year vision for antimicrobial resistance. And that was published back in 2019, and it has an ambitious goal of ensuring AMR will be controlled and contained by 2040. Clearly, the pandemic has moved that plan in different ways, but the principle underlying it is very much along this agenda of working in a One Health environment. So another example is our HARES group. Now that's very confusing to our ministers. It's nothing to do with the thing that's on your head. It's an acronym for the Human Animal Infections and Risk Surveillance Group, HARES. That's a multi-agency cross-government group, routinely met since 2004, and it assesses, risk assesses emerging and potential zoonotic infections which may pose a threat to the UK public health. And then they're taken forward by each of the individual government departments. And then a past opportunity, a newer initiative, is called PathSafe, another acronym, and this is for the Pathogen Surveillance in Agriculture, Food and Environment programme. Again, piloting a national surveillance network using genome sequencing technology, and that improves the detection and tracking of foodborne human pathogens through the whole agri-food system right from fork to farm. But what we're trying to do now is actually look at how we can take our learning from these successes and start to apply them to more progressive ways of integrating the One Health approach much earlier, and by doing so, increasing efficiencies and getting better knowledge across our systems. Now, one of the good things about being a new health security agency is that we got that title, and in it we have the word health security. And that has helped us bring actively and formally into the UK's national security system our whole organisation, and with it a much greater whole government awareness of biosecurity risks and opportunities to mitigate and combat them. So although there was a biological security strategy previously, there was a new one published post-pandemic in 2023. And I won't go through the detail of the slide, but what you can see is that this strategy emphasises One Health throughout, through biosurveillance and threat detection, through interconnected global surveillance, and through multi-sectoral collaboration. And over on the right-hand side, you'll see that the UKHSA has some key deliverables in that detect pillar, and one of those is the National Biosurveillance Network to enhance protection in the UK from known and emerging high-consequence biological threats. Now, the National Biosurveillance Network is looking to see if it is feasible, and I referenced Natalie's slide, to collaborate on surveillance of priority pathogens, and importantly to see if all sectors can see the benefits of that engagement in developing processes and governance for this type of collaborative surveillance, because historically often what's happened is we have human health-centric activities, we brand them as One Health, but in reality there has been very little benefit to engagement for the other sectors. And so in this work, what we're trying to do is explicitly understand the benefits and the opportunities to make any outcome, product or process much more desirable, accessible, jointly owned and enabled. I think I'm going to just jump a little bit, but what I want to do here is just show you this slide. You will not be able to see the details, so I'm hoping it will win the prize for the most complicated graphic that we have had right at the end of the day. But what it actually shows is the aim of the NBN, the National Biosurveillance Network, is to pick up those three key factors around people, animal, and plants, and you can see that in the sort of orangey colour. And then each of the organisations, and this is the UK alone, each of the three parts of that circle is one of the animal, plant, or human, animal, or environment. Each of those three parts is divided into four because we have for UK nations, and we all have slightly different mechanisms. And then as you go from the inside out, you will see that this goes through detection up to response in the outer side. And within it, the symbols represent a whole lot of different organisations, whether it be academia, private industry, or the health institutions that we're aware of. So in summary, the aim of that National Biosurveillance Network is going to be to provide an early warning for known and emerging biological threats to national security, but also to drive data standardisation and quality, to improve policy decisions and resource allocations, and simultaneously deliver cost savings for healthcare, for industry, and wider government. And it should establish a single source of truth for biothreat data and analysis. But of course, our work, like everyone's here, is global, and while it should enhance UK-led global health security policy and diplomacy, it should also enhance disease surveillance and response opportunities globally, so helping prevent the spread of infectious disease at source, across borders, and then back to UK communities. So in summary, the One Health approach has the potential to significantly enhance the resilience of health systems and in turn global health security, provided that we as a global community can sustainably operationalise it. We need to learn from one another's successes, failures and solutions, and UKHSA is committed to sharing our learning with others to strengthen professional workforce and to support integration across the system. And we will look to increase our engagement with peer learning and through information sharing forums like the Global Health Security Agenda and the newly established G20 network of One Health institutes. So I think to finish, I propose there are 3 messages for you today on the slides. I think by investing in peer-to-peer learning and information sharing, we can build a compelling investment case for the One Health approach, demonstrating to political leaders how it can enhance the operational, strategic, financial and policy effectiveness of governments. But as always, with almost everything we do here, to realise this vision, we have to strategically communicate, coordinate and collaborate and recognise that our shared success is essential for bolstering global health resilience for all. Thank you.
Thank you so much, Professor Jenny Harris, for sharing this experience and the role of UK Health Security Agency in leading this pilot of the National Biosurveillance Network and how to operationalize this interdisciplinary work in this One Health approach. I will ask for some help regarding time. If we still have some time to discuss with the audience, probably it will be interesting now to pass the word to audience, because so many challenges, different presentations that we had here in this panel. They somehow complement each other, but they had different approaches, strategies, experiences, innovations. And we totally agree that in essential, every one of these experiences, it's important to build resilience, and that's in the mission of National Public Health Institutes. So I would like now open the floor to the audience to ask if who wants to put some question or to some of the presenters, or global question that everyone could address. Yes, we have one.
I'm going to ask basically to everyone, one of the things that struck me was that everybody highlighted the need for an interdisciplinary workforce in one way or another. So I think that was a really strong theme, actually all of today coming out. So I wondered, just in terms of the discussion.
We cannot understand very well.
Sorry. So I thought just one of the
Okay.
things that really came out for me in this session, as it did in the sessions really throughout today, was this need for the interdisciplinary workforce. And Natalie highlighted it, but we heard also we heard very different aspects of that. But I wondered if this is the session where we're also thinking around what can we ask for the G20 in supporting resilient NPHIs. Maybe we could think around a concrete recommendation on that type of workforce. Maybe that would be something the rapporteurs and chairs could consider. So it's a comment or a suggestion, and I'm happy to hear people argue against it or for it if you want to, as a question. Thank you.
Thank you so much. I don't know if someone from the panelists would like to comment.
Can you hear me? Yes. So it's a great question, and I also not sure whether I think it's a good one or not. The reason I say is because we talk about interdisciplinary work and workforce, and we absolutely need people to work across boundaries. But there is then a temptation where everybody starts becoming the same. And actually what we need is specialists, and this is where I would challenge, specialists who have both the culture within themselves to reach out and respect other disciplines, and then environments, workplaces, politicians, whatever the setup is, that enable them to do that. And so I think often, if I look back at some of the problem areas we've had, I can find super enthusiastic people who will share their skills willingly, and sometimes not. And where I find there are problems, it may relate to siloed funding streams in government chains, or resource limitations in one area and not another. So classically, you will, I mean, I'm doing health protection now, but I'm a sort of broad public health physician by background. And so if I was working in local government previously, I would find that a funding stream had suddenly been stopped. There was a willingness to work across boundaries. We had the workforce originally, and then it moved. So I'm not sure whether it's an interdisciplinary thing or whether it's actually a workforce capacity issue, and we need sustainable resourcing and recognition.
One more question. Just a comment.
Can I come back on that then? So I think maybe I'll amend my question or suggestion that we have a specific recommendation around the workforce, recognizing that that is from different disciplines, but that is vital for an investment for resilient health systems or something like that. The rapporteurs will find a way.
That's a much easier question. I agree.
Very good idea. Meng?
Thank you. Meng Kaur, Public Health Wales. I was really struck by the narrative, the compelling need to build a One Health understanding. And I wondered whether there's something about making a recommendation to actually mature our understanding of not just human health, but also plant and animal health. Because if you ask me to describe what the animal health system is like, I wouldn't know where to start.
We're smiling on the stand here because Tana and I had a conversation earlier about H5N1, and I'm sure there will be US colleagues in the room, and trying to understand how the US farms cattle, which is entirely different to how that happens in the UK. So part of our H5N1 response or preparedness has been actually to learn farming process in the US. So it absolutely highlights the point that Meng has just said, and also that we noted there are very different systems across the world, and unless we're aware of them, we can't do appropriate risk assessments.
I think that something that is really missing here, when you're talking about One Health, is the transsectoral bridge, right? And I think that's something that is happening across all countries. I mean, that is something that we see in Mexico. We are not necessarily up to date on what is being done specifically for animal or plant surveillance, simply because although we may be aware of the concept and we may want to move there, this transsectoral space doesn't exist. So in Mexico, for instance, we're trying to do transsectoral work now for food systems, right? So we are basically sitting with agriculture, and so everybody that has to do with food production and the food system is sitting at that table. And we are hoping that that system is going to work towards being able to do something on the One Health perspective. But of course, we are still doing, like the first 3 steps, and we feel that we should be already running a marathon. Yeah.
If I could chime in on that point, maybe bringing together Jenny's observation about high-path avian flu and the importance of systems across boundaries. For our preparedness efforts in Canada on that front, we've had to create tables that can work in a much more nimble and collaborative way, bringing together for routine meetings the Council of Chief Medical Officers of Health with the Council of Chief Veterinary Officers, who have met periodically, but the need for ongoing discussion. The laboratory collaboration between the Food Inspection Agency and the Public Health Agency of Canada, housed in the same building, but needing to ensure that we are working closely together so that the surveillance for animal health and how that is evolving and the risk assessment in the animal health space can inform the development of triggers for preparedness activities in the human health space. And so just really appreciate that observation around transboundary collaboration.
Some more questions, and we still have time.
I go ahead? Okay. Yeah, I have a question. So we talk a lot about collaboration among the different health sectors, One Health, agencies, and so on. Would there be any comments by the panel about working across different sectors? I think from the COVID pandemic, certainly you mentioned about H5N1 outbreaks or even Mpox. There is a strong interaction between health sectors and other sectors such as economic sectors, education, travel, transportation, and many others. How do we better engage these other sectors within government and between the public and private institutions as well, to harness the collective capabilities of all the different sectors, because there's a lot of impact that health problems have on the other sectors and vice versa as well. And what are the roles of the national public health institutions in facilitating this by providing either evidence, solutions, and proposing different measures to work and harness these capabilities across the different sectors? Thanks. Oh, sorry, I forgot to introduce myself. I'm Vernon Lee from the Communicable Diseases Agency, the interim agency in Singapore. Thanks.
Thanks for that question. I think it's all about co-value creation. And I think when you interact is what is the need of both parties and how can you leverage on the resources between both parties to meet that mutual need. And I think sometimes it's a simple thing like using the platforms of communication of, for example, a private sector to translate information of an outbreak. And I think it can be as simple as that, and it can go far more complex. But I think the principle is around co-value creation and mutual collaboration in collectively solving problems.
Thank you. Maybe just to reflect on the role of the National Public Health Institute, and we've been promoting, because this National Public Health Institute, the main role of this NPHI is coordination. And when we talk about coordination, also when we are talking about the IHR, and in most of the countries, actually in most of the countries, we know the NPHIs as the national focal points for IHR. And IHR implementation looks for a multi-sectoral coordination. And when you see the key elements of the IHR, which is looking about this food safety, zoonotic disease, chemical hazards, nuclear hazards, and the epidemics, they are part of the IHR component. So to develop capacity around these things, you need a multi-sectoral coordination mechanism. So the NPHIs can play, this coordination role by organizing or establishing of a national coordination mechanisms to address the IHR requirements, as most of the core functions or the core capacities of IHR fall within the mandates of the national public health agency. So I think the critical role of the NPHIs are part to providing evidence and science, to influence policies and decision is a coordination role they have, in terms of the implementation of the IHR and the global health security agenda at a national level. Thank you.
Professor Paulo Russo.
Muito obrigado. Eu queria... Bom, vou falar em português. Eu queria agradecer o painel e fazer um comentário que o mais apropriado, a minha pergunta, seria ser feito pela minha colega Cristiane Machado, que é vice-presidente da Fundação Oswaldo Cruz para sistemas de saúde, quer dizer, para ensino, para formação de recursos humanos. E a minha pergunta eu vi o professor, o diretor do Instituto Nacional de Saúde do Japão, que falou de uma importantíssima formação de recursos humanos, 56 mil pessoas, 1.500, os números são gigantescos, não é? Para um país, enfim, não tão grande, e eu quero cumprimentar o Instituto pelo grande papel na formação de recursos humanos. Os nossos institutos são muito diferentes um do outro, não é? A Fiocruz, nesse sentido, ela se aproxima muito do Instituto do México, que tem uma Escola Nacional de Saúde Pública, como nós. Se aproxima muito, nesse sentido, ao Instituto do Japão, que tem uma grande formação de recursos humanos. Creio eu, pelo que entendi, que o centro no Canadá, o centro UK e o centro na África do Sul, do Instituto Nacional de Saúde Pública, não vi menção à formação de recursos humanos. E a minha pergunta é um pouco isso. Nós somos diversos, e isso é muito bom, mas eu tenho curiosidade porque, antes de ser presidente da Fiocruz, na década 2000, por 8 anos, eu era exatamente o vice-presidente de ensino, de educação. E nós tínhamos um grande programa de especializações, um programa de educação à distância, que agora é muito grande. Nós temos uma escola de governo e temos a chamada UNASUS, Universidade Aberta do Sistema Único de Saúde, UNASUS, com um grande programa de formação localizado, não aqui no Rio de Janeiro, mas na capital federal, em Brasília. Um grande programa de pós-graduação, de especialização em educação à distância. Então, a Fiocruz trabalha educação à distância. Cristina, vou entrar no seu campo aqui, mas eu tinha pensado de você fazer a questão. Mas como eu estive no lugar dela, me sinto autorizado a fazer essa pergunta. Qual é o papel dos institutos na formação de recursos humanos do sistema de saúde? Também não sei em Portugal como é a coisa. Eu sei que em alguns países na África, os institutos não têm, entre aspas, autorização para formar recursos humanos. Isso é universidade, e os institutos tinham um bloqueio. O setor de educação não gostava. Aqui no Brasil, não. Nós temos uma fluidez de universidades e institutos podem formar recursos humanos, inclusive em pós-graduação. Mestrados, doutorados. A Fiocruz tem mestrados e doutorados. São 16 ou 20 programas. Sei lá, depois a Cristina vai falar. Então, a minha pergunta qual é o papel destes institutos que estão à mesa e também dos institutos, se alguém quiser colaborar, dos demais institutos, na formação de recursos humanos para a saúde pública?
Eu se calhar posso... vou falar agora em português também, um bocadinho. Eu se calhar podia começar a falar da experiência do Instituto Nacional de Saúde, Dr. Ricardo Jorge, em Portugal. Nós não temos programas de formação, de pós-graduação, de mestrado. Nós colaboramos com outras instituições universitárias e aqui falamos um bocadinho de parcerias. Nós somos fazemos estas parcerias em que parte da formação é feita numa instituição universitária e a parte prática, a parte laboratorial, a parte hands-on é muito feita no Instituto Nacional de Saúde. E estas parcerias funcionam bem, porque temos protocolos com a maior parte das universidades em Portugal. O Instituto foca-se muito no treino, por exemplo, de médicos de saúde pública, de profissionais de saúde pública, de treinos especializados de curta duração, 3 meses, 6 meses, até 1 ano, de acordo com as necessidades. Claro que nós não competimos, há a Escola Nacional de Saúde Pública, que é diferente, o sistema é diferente e que tem aí sim esses treinos específicos, mas acho que o nosso papel, a nossa forma de estar nesta framework nacional se complementa com as universidades, com as escolas, com a Escola Nacional de Saúde Pública e que em consonância conseguimos providenciar esta formação especializada. Nós temos também pedidos, por exemplo, de empresas que nos pedem formação específica, por exemplo, áreas tão específicas como qualidade do ar interior, um problema também dos nossos dias. Avaliação dos sistemas de legionela, por exemplo, áreas específicas que a instituição tem capacidade para e é altamente especializada no país e que recebe estes pedidos de formação específica que muitas vezes são feitos ad hoc ou existem para quem quiser. Alguns deles são gratuitos, outros não. Por exemplo, formação em mass gatherings, outra área que não existe nas universidades. Ou seja, funcionamos um bocadinho também colmatando algumas lacunas que existem na formação avançada em Portugal.
Thank you for your question. And I think in Japan also we have many NPH courses in the university, graduate school, but I think NPH course is very related to general capacity in public health. But National Institute of Public Health, our institute, are more specific to a national policy and local implementation of the policy. So it's a little bit different from NPH course and our training course. And also nowadays, local government is very tight in human resources. Very tight in human resources. They cannot provide health officers NPH course, 2 years course. So we are providing them to very short courses. Longer course is just a 3 month. So it's a very closely related national health policy itself. So it is a very important role of National Public Health Institute in general. Thank you.
I don't know if I should speak in English or Spanish. I think I'll go with English just to. So IANPHI in Mexico is actually working, has been working for many years, to provide advanced level education, like masters and doctoral degrees. But we are seeing something similar to Japan in the past years, in which the demand for the type of courses that we are seeing is for much shorter duration of courses. And something that is happening is that we are seeing both changes in the way in which the system works that requires people to get more frequent training. And the second thing that is also happening is that for many levels of service in the health system, there's a lot of rotation of people. So people comes in and out, and you have to be training people, to keep that pace. And we have been able, to provide that using virtual, like these massive online courses that have been extremely successful. My main concern now is that given the speed at which things are changing, sometimes we have difficulties understanding, how can we best serve those training needs. And sometimes, for instance, if you're going to be teaching epidemiology, you're always having this tendency towards trying to provide very advanced knowledge, like causal inference, for instance. And that is something that is not necessarily required to provide some of those services. So we have found that it's extremely important to keep a very open communication as to what are the very specific needs that need to be solved through training.
In Canada, I'll offer a few reflections. Since the creation of the agency, we went from having a couple of Masters of Public Health programs in the country, no Doctor of Public Health program, to programs across the country, more than 20 Masters of Public Health programs, now a couple of Doctor of Public Health programs. We also have a number of Masters in Science in Public Health programs that interface. And so the practitioner stream and the science and research stream is something that we, I would say, equally need to benefit from as an employer and create practicum opportunities and study opportunities for students. In terms of our connectivity to setting sort of norms and standards for the public health workforce, we do that in part by funding the National Collaborating Centers for Public Health. And the 6 National Collaborating Centers deal with, so we are the primary funder of those centers, and they've been established at the outset of the agency. So they're mature organizations in and of themselves that have existed for 20 years. We support them to be connected much more to the local level and to create networks across the country of practitioner support. And they provide courses for professional development of practitioners. They're currently leading the refresh of our core competencies in public health, a document that needed to be modernized for both the schools and programs in public health that have expanded so considerably, but also for the broader public health workforce. And so that set of core competencies for public health is something that will be released in the coming year and reflective of the core public health functions for practice.
So I think we all have slightly different arrangements. So the UKHSA doesn't award any academic titles itself. But I'd hesitate to guess, but about half our workforce will have masters in public health, for example. But the breadth of the specialisms that we have, I was just noting down when you were talking. So we have microbiologists, we have doctors, we have epidemiologists, we have geologists, we have radiologists, we have almost everything, data scientists increasingly. And so we do have internally standards that we maintain, and we support each of those individuals to ensure that, and we require them to be up to the standards with continuous professional development for their own career path. We do provide some very specialist training, for example, around specialist laboratory management, because that's rare and it's a thing that we can do. But I think broadly we work with universities, and many of our senior staff have both a role in UKHSA and they have a role in the university. We call them twin hatters.
So at the NICD, very similar to the UK, we don't accredit and provide the degree or qualification, but we work very closely with the universities. Most of our staff have joint appointments with the universities. So we teach at undergraduate level, postgraduate level, postdoc level. One of the things that we do is the field epidemiology training program. And to answer Joanna's question, this is a vehicle for interdisciplinary training. And I think this is maybe a recommendation that there's a stronger support from G20 for this interdisciplinary training method through the field epidemiology training program. And to model that on Africa CDC's intervention, it's not only the field epidemiology, but expanding into health informatics. And I think the data science is becoming increasingly important. And I think this is going to be an area that I think we do need to have further investment into expanding health informatics and data science. Thanks.
We still have some more questions. First, Zimbabwe.
Thank you very much, Madam Chair. I think you reached far south at last. Just to remind you, we have an IANPHI professional development group looking at the issue of public health workforce, which I presented. And I hope that we can use that platform together with WHO to address this issue of the current public health workforce and the others, and the general health workforce, and to increase investment and competency skills as well. This was actually launched at the G20 by Rome, by Italy. And I think we need to be consistent to follow this up and report back and take it forward, because the workforce is the largest investment in health systems and public health systems. I just then want to make one or two comments. Multisectoral, interdisciplinary is easy to say, but extremely difficult to do in terms of who and how and where and when. So we need to learn from our experiences in this area of multisectoral, intersectoral. The other thing is, I think global health is missing the public health. So I would really re-emphasize that. Why? Because there has been a generation of lots of words and terminology, and the latest one is resilience. Another one is One Health. And I think we need to reflect on these definitions and get a bit of coherence and alignment. Otherwise, our goals and objectives become affected. And this is why, for example, some very well-established public health institutions have lost the confidence of the people and the public, and the politicians and the policymakers. So there is a lot of reform going on, and we need to be aware that public health has been very low profile. And if we don't use this opportunity properly, we'll end up with similar problems. Thank you.
Thank you so much for the comment, well noted. We are running out of time, but we still have two persons that want to put some quick questions, please, or comments.
Hello. All right. No, thank you for giving me the floor. If you look at the essential public health function, you will see that workforce is one of those essential public health functions that is expected of the NPHI to perform. Now, when you look at the continent of Africa, most of the field epidemiology training programs are actually done by the NPHIs. You know, and to address the issue of whether short-term, medium, or long-term. So there are 3 levels of that field epidemiology training program. We have the front line, that is just 3 months. We have the intermediate, 9 months. And we have the 18 months. So usually the 18 months is done in conjunction with the universities, so that at the end of the day it's a degree awarding program. But for the front line and the intermediate, these are just purely competency-based programs. Now, for Africa CDC to complement that, as Natalie has rightly mentioned, we also have what we call the African Epidemic Services, which is modeled after the US EIS program and the ECDC EPH program. So my big request to the G20 is the fact that most of our member state field epidemiology training program are currently struggling. They are really struggling. It's a program that has been largely supported by USCDC, for quite some time now. So we welcome more investment into that space, as well as the Africa CDC, African Epidemic Services. So really, the NPHIs have a big role to play as far as the public workforce development is concerned. Thank you.
Thank you so much. Tiago, last question. In Portuguese.
Is it? Yeah, sorry. Yeah. In português. Depois de ouvir a doutora Cristina falar sobre o caso português, permitam-me elaborar um pouco mais sobre isso, porque às vezes causa surpresa na IANPHI haver 2 institutos nacionais de saúde pública, como é o nosso caso. O Instituto Ricardo Jorge, que é o Laboratório Nacional, mandatado pelo Ministério da Saúde e, portanto, faz parte do Ministério da Saúde, e o Instituto de Higiene e Medicina Tropical, que faz parte do Ministério da Ciência, e é uma universidade. E se há casos como o Brasil ou o Japão, em que os Institutos Nacionais de Saúde Pública providenciam a formação e o treino, em Portugal isso não acontece. E isso significa, talvez esta seja a mensagem central, é que cada país deve refletir até que ponto os Institutos Nacionais de Saúde Pública estão a treinar, a formar e a pensar os recursos humanos na saúde, se podem fazer isso ou se não podem. Porque se puderem, devem fazer. Mas em alguns casos, como por exemplo em Portugal, não fazem, e nessa medida é preciso esta combinação de institutos mais laboratoriais e institutos académicos. E, portanto, em Portugal, o Instituto de Higiene e Medicina Tropical faz a formação pós-graduada em saúde pública, em saúde global, em microbiologia, em virologia, em doenças negligenciadas. Nós temos o Centro Colaborador da OMS para o planeamento e políticas da força de trabalho em saúde. E é esta combinação virtuosa que eu gostaria de expor aqui, que de país para país vai variar, mas no essencial os Institutos Nacionais de Saúde Pública têm que pensar têm que pensar a formação dos recursos humanos que são essenciais ao cumprimento da missão essencial da saúde pública. E têm que, sobretudo, pensar como reter os profissionais, como motivar os profissionais, porque o turnover, a substituição de recursos humanos, está a limitar muito a capacidade que os vários países têm tido para assegurar as core functions, as funções essenciais da saúde pública. E, portanto, eu direi que é este compromisso com os recursos humanos que também deve ser veiculado nesta reunião, quer seja pelos institutos de saúde pública no sentido de laboratórios, quer seja por instituições universitárias que têm que estar intimamente ligadas, umbilicalmente ligadas com os laboratórios. Obrigado.
Muito obrigada. Eu acho que temos que terminar agora as questões e se houver mais dúvidas, comentários, podem ser feitos no coffee break. E iria passar à doutora Cristiane Machado, enquanto rapporteur, para fazer aqui a súmula desta nossa sessão, deste painel.
Good afternoon, everyone. Boa tarde. Eu vou falar em português. Tentarei falar devagar para facilitar o trabalho dos tradutores, que meus estudantes dizem que eu falo muito rápido. Em nome da Fiocruz, em primeiro lugar, eu queria reiterar os agradecimentos ao IANPHI, ao CDC África, pela parceria na organização desse evento e agradecer a presença de todos os senhores. O encontro está sendo muito rico, estamos todos aprendendo muito, então, desde ontem, tivemos vários painéis extremamente interessantes. Também queria agradecer a oportunidade de ser relatora desse painel, que foi muito rico, tivemos exposições densas e muito complementares e que também tem uma sinergia com os painéis anteriores, como já foi mencionado aqui por Cristina. Eu não vou ter condições de fazer comentários sobre cada fala, então procurei fazer apontamentos de pontos que se destacaram na fala de vários dos palestrantes, né? E que são estratégicos, a meu ver, para as recomendações que os Institutos Nacionais de Saúde Pública devem fazer aos Ministérios da Saúde para que influenciem as políticas públicas, os governos. Uma consideração inicial que eu gostaria de fazer é sobre a própria concepção de resiliência dos sistemas de saúde, porque, a meu ver, ela é muito importante, mas, como os senhores abordaram bem em suas falas, ela não é suficiente se queremos expandir o acesso à saúde de uma forma universal, sustentável, promover a equidade em saúde e dar conta de um conjunto muito complexo de problemas de saúde que atualmente transcendem as doenças infecciosas e as situações de crise, como doenças cardiovasculares, diabetes, que foi citada aqui, como os problemas de saúde mental, como as neoplasias, uma série de problemas, as violências, enfim. Então, nós precisamos construir sistemas nacionais de saúde que sejam públicos, robustos, abrangentes, integrados e orientados para o acesso universal e a equidade e com qualidade, como também foi destacado. Alcançando esses sistemas robustos, fortes e integrados, nós teremos mais condições de que eles sejam resilientes diante de crises ou de emergências que se coloquem, sem prejuízo também de desenvolver capacidades específicas, obviamente, para a resposta a emergências sanitárias e a crises, desastres de diversas ordens. Então, um primeiro bloco de comentários que eu vou fazer, a partir das contribuições dos nossos palestrantes, diz respeito aos requisitos para fortalecer sistemas públicos de saúde que alcancem esses objetivos do acesso universal e da equidade, né? Para isso, é necessário enfrentar problemas estruturais que foram destacados pelos palestrantes. Nossos sistemas de saúde são muito diferentes, mas é impressionante ver como alguns dos problemas estruturais são comuns a vários deles. Então, o primeiro desafio que eu apontaria é a necessidade de superar a excessiva fragmentação organizacional e segmentação por clientela nos sistemas de saúde, que isso é fundamental para alcançar acesso universal, maior abrangência das ações e equidade. Também foi abordado o desafio de articular políticas nacionais e implementação local. É claro que isso dá de forma diferente nos vários países, a depender da configuração dos sistemas políticos, territoriais e dos sistemas de saúde. Aqui nós temos, por exemplo, algumas federações representadas em que esse debate é muito forte, né? México, Canadá, África do Sul, no próprio caso brasileiro, mas também a gente viu que em outros países de organização político-territorial unitária, a relação entre políticas nacionais e implementação local e relação entre as autoridades de saúde se faz necessária e seu diálogo com as comunidades locais. Um dos temas mais destacados nesse painel e nos vários painéis anteriores foi a questão da força de trabalho em saúde. A necessidade de assegurar a disponibilidade de profissionais de saúde, a fixação desses profissionais, que foi novamente mencionada, em condições de trabalho adequadas, além dos desafios que foram ressaltados de formação e qualificação dos profissionais de saúde para as diversas responsabilidades em saúde pública, desde a gestão do sistema à implementação de ações, né, no plano nacional e no plano local. Mencionou-se também a necessidade de ter na base do sistema tanto funções essenciais de saúde pública, como também uma atenção primária à saúde forte, abrangente, de base territorial e comunitária, com profissionais qualificados. A atenção primária à saúde, nessa perspectiva, deve estar articulada a ações de vigilância em saúde, e não de forma segmentada, fragmentada, e a outros níveis de atenção. E deve ser gratuita, sem pagamento de taxas de qualquer natureza. A experiência brasileira mostra a importância de trabalhar com equipes multidisciplinares na APS, no nosso caso, o Saúde da Família, que foi citado aqui por alguns colegas desde ontem, ele envolve médico, equipe de enfermagem e agentes comunitários de saúde que são recrutados na própria comunidade e trabalham muito próximo às necessidades locais e às culturas, etc. E essa questão da vinculação ao território é fundamental, assim como assegurar a continuidade do cuidado para os demais níveis de atenção. Bem, outro ponto muito importante diz respeito à vigilância em saúde, e se destacou aqui a importância de que ela não seja restrita ou fragmentada por problemas específicos de saúde, mas sim que adotemos abordagens mais integradas no interior das estruturas e agências da saúde, nos vários níveis do sistema de saúde, do nacional ao local, e que ela tenha também caráter multissetorial e transversal aos diversos atores, né, envolvidos, incorporando parâmetros sociais e também lidando com outros agentes do sistema político. Nesse sentido, os expositores trouxeram contribuições como as concepções de saúde única e de vigilância multissetorial, como estratégias para tentar romper com a organização da vigilância muito fragmentada em silos, por doenças, por órgãos ou setores. É claro que, como foi falado também, é um desafio muito grande operacionalizar a intersetorialidade, mas eu diria que um passo importante é a própria integração dentro das estruturas de saúde, porque nós ainda mantemos uma tradição de trabalhar muito fragmentadamente por doenças ou por problemas específicos. Outro aspecto que vem sendo abordado desde ontem é o caráter estratégico das políticas de ciência, tecnologia e inovação em saúde, incluindo, quando possível, o desenvolvimento e a produção nacional de insumos. Se queremos ter sistemas de saúde robustos com capacidade de responder às necessidades de saúde das nossas populações, precisamos assegurar o acesso de todas as pessoas a vacinas, medicamentos, testes diagnósticos e reduzir as assimetrias mundiais nesse âmbito. Para tudo isso, é necessário assegurar o financiamento público suficiente e infraestrutura adequada nos sistemas de saúde, com investimento em capacidades permanentes do sistema, além de projetos específicos, como muitas vezes os financiamentos internacionais visam fomentar ações específicas, né? E também além da resposta a emergências, em que às vezes há fluxos de recursos extraordinários. Mas é necessário ter financiamento público estável, suficiente, que dê segurança e sustentabilidade aos sistemas de saúde, para haver continuidade, coerência entre das políticas e das ações ao longo do tempo. Para isso, também é fundamental construir base legal, planejamento, arranjos institucionais que assegurem compromisso político dos dirigentes e estabilidade. Abordou-se também no painel a importância de desenvolver sistemas de informações em saúde e capacidades em análise e interpretação de dados e de indicadores nos planos nacional e local que permitam orientar decisões e políticas, bem como monitoramento e a avaliação das ações. Se estamos falando de fortalecimento dos sistemas públicos de saúde, também precisamos considerar a dimensão das relações público-privadas no sistema e a necessidade de regulação do setor privado em saúde. E aí, a falar no setor privado, estou abordando tanto empresas, que são empresas que atuam fornecendo insumos, como os prestadores privados, seguradoras privadas, que atuam na maior parte dos nossos países. A literatura é abundante em demonstrar que sistemas de saúde em que o setor privado é muito forte tendem a ser mais desiguais e o crescimento de segmentos privados sob escassa regulação estatal ou mesmo sob subsídios do Estado pode aumentar as iniquidades. Esse foi um primeiro bloco de questões relativos aos desafios estruturais dos sistemas de saúde que devem ser enfrentados. O que os Institutos Nacionais de Saúde Pública podem fazer para contribuir para esse enfrentamento? Então, o segundo bloco de comentários, e eu vou fechar em breve, diz respeito ao papel dos Institutos Nacionais de Saúde Pública e a necessidade de fortalecê-los. Essa recomendação nós precisamos explicitar como organizações que articulam conhecimento científico com proposição de políticas e que precisam, para isso, ter sustentação legal, financiamento adequado o suficiente e equipes multidisciplinares, como foi apontado por alguns dos nossos colegas. E quais seriam, então, as funções estratégicas dos próprios Institutos Nacionais de Saúde Pública, respeitando aí que existem muitas diferenças entre os nossos institutos. A primeira, que foi bastante mencionada, é desenvolver pesquisas e estudos nesses vários eixos relevantes para os sistemas de saúde, para produzir conhecimento e evidências visando subsidiar políticas públicas, apoiar e monitorar a sua implementação. O segundo eixo, e que foi retomado agora e na intervenção do meu colega Paulo Bus, é a necessidade de atuar para a formação e qualificação dos profissionais de saúde nas várias funções do sistema de saúde. Isso pode ser feito de forma diferente, tanto diretamente, como é o caso de alguns dos nossos institutos. A Fiocruz tem uma atuação importantíssima na educação em saúde, e isso foi fundamental, inclusive para a construção de um sistema único de saúde e para o seu fortalecimento e sustentação nos últimos 35 anos, né? Paulo mencionou aqui alguns números. Atualmente, nós temos 46 programas de pós-graduação, mestrado e doutorado. Oferecemos cerca de 50 cursos de especialização por ano, muitos cursos de qualificação profissional, temos residências também, médicas e multiprofissionais, e qualificação profissional tanto on-site como online, né? Só na pandemia de Covid-19, nós treinamos mais 400 mil profissionais online para lidar com a Covid-19. Então, isso, no caso da Fiocruz, foi uma potência muito importante que está espalhada no território nacional. Mas nós também trabalhamos em parceria com universidades, e eu considero que isso é muito importante. Alguns dos institutos fazem isso, podem não oferecer formação direta, mas trabalham de forma articulada com outras instituições formadoras. Uma terceira função estratégica é atuar na ciência, tecnologia, inovação e saúde dentro das especificidades de cada contexto, subsidiando políticas nessas áreas, né, discutindo a questão da regulação da CIT, incorporação tecnológica, avaliação de tecnologias. Em alguns casos, até mesmo no desenvolvimento e na produção direta de insumos e tecnologias, como é o caso da Fiocruz, mas nós sabemos que não são muitos institutos que são produtores, né? Isso é mais raro. No nosso caso, no caso brasileiro, foi extremamente importante e tem sido extremamente importante para a sustentabilidade de um sistema que atende mais de 200 milhões de pessoas, enfim. Uma outra função é prover conhecimento para a promoção da equidade e redução das desigualdades, que é o tema que nós estamos discutindo aqui desde a manhã. Um outro aspecto muito estratégico seria assegurar estabilidade às políticas e ao sistema de saúde, fornecendo institucionalidade e legitimidade social. Os Institutos Nacionais de Saúde Pública devem cobrar o compromisso dos governos e assegurar a continuidade das políticas e ações no sistema de saúde, mesmo em situações de instabilidade política e de governos que não têm compromisso com a saúde da população. E aí eu tenho que falar de novo da experiência brasileira. No caso da Fiocruz, nós vivemos isso em governos que tinham posições extremamente nefastas do ponto de vista da ciência e da saúde, e na pandemia, a pandemia foi um momento muito difícil, e a atuação da Fiocruz foi fundamental para assegurar essa legitimidade do sistema de saúde e a continuidade das ações em um cenário muito adverso. Uma outra questão estratégica, que também foi ressaltada, é fortalecer a cooperação internacional. Os Institutos Nacionais de Saúde Pública juntos são mais fortes. E aí eu queria saudar os fundadores da IANPHI, né, como já foi falado aqui desde ontem, porque isso foi uma iniciativa realmente de extrema relevância. Os institutos podem aprender uns com os outros, com os acertos e erros dos sistemas de saúde e da própria atuação dos institutos, e há muitas possibilidades para expandir parcerias. Eu já diria aqui que um outro desafio, à luz do que eu escutei esses dias, é até mesmo fazer um diagnóstico grande de qual é a situação dos institutos atualmente, né? Quais são as especificidades, para a gente ter um mapeamento dessa diversidade e do potencial aí colaborativo. Por fim, um papel muito importante dos institutos nacionais é a participação em instâncias e iniciativas de coordenação global de saúde, buscando um novo balanço na saúde global, com solidariedade e equidade entre as nações e os povos. Muito obrigada pela oportunidade.
Queria só aproveitar para pedir também uma grande salva de palmas para todos os apresentadores desta sessão. E dizer que a Cristiane foi excepcional na forma como resumi todas as ideias, inúmeras, múltiplas dimensões do que foi aqui discutido hoje. Muitos parabéns a todos. Muito obrigada.
Agradecemos muito por esse painel, agradecemos aos panelistas, senhora coordenadora, senhora relatora. Nesse momento, temos um intervalo.